Hi, everyone. Welcome to another multi-heart lecture series. Today, it's a great pleasure to introduce Dr. Charles German. Dr. German will be talking about physical activity for the general cardiologist, what you need to know. It's a great honor to have him here. Dr. German is an assistant professor at Georgetown University and is the director of preventive cardiology at MedStar Georgetown University Hospital. He completed a 4-year T32 cardiology fellowship at Wake Forest University, obtaining an MS in epidemiology with a dedicated year of preventive cardiology training where he did great work with Mike Shapiro. He is a board-certified cardiologist and cardiovascular epidemiologist with research expertise in physical activity, coronary calcium scoring, risk assessment, and cardiometabolic disease with publications in great journals like JAMA, JACC, Hypertension, and others. He has served on the Physical Activity and Obesity Councils for the American Heart Association and helped plan the AHA's preventive cardiology programming for scientific sessions over the past 2 years. He also serves on the board of the American Society for Preventive Cardiology, where we share a position, and he has chaired also the clinical practice statement entitled Defining Preventive Cardiology. He will be speaking today about a very important topic of physical activity and exercise as therapy. So we're very excited for your lecture. Thank you very much for joining us.
Thank you so much, Leandro, for that very kind introduction. I'm very excited, delighted to give this talk on one of my favorite topics, physical activity. And really the focus here is going to be on what you need to know as a general cardiologist about physical activity and how it's important for cardiovascular health. So the outline for today's talk, first we'll touch on the epidemiology of physical inactivity and define what that means. We'll go over the guidelines. We'll talk a little bit about physical activity intensity, or different ways to measure intensity, focus specifically on METs or metabolic equivalents, and then moderate to vigorous physical activity. We'll also touch on the literature on steps, potential harms of specifically high intensity physical activity, and then we'll end on assessing and prescribing physical activity, something easy that everyone can do in clinic. Okay, so the problem here is that I think for this audience specifically, cardiovascular disease rates are increasing, which is quite, I think, deflating. We know from the 1950s or so that cardiovascular disease rates have been decreasing, have been improving, but since about 1990, maybe a little bit earlier than that or so, the rates have stagnated and in fact are increasing. What is causing this? It's probably due to increasing rates of obesity and diabetes leading to cardiometabolic diseases. And this is data from the Global Burden of Disease study. And they've estimated that deaths due to cardiovascular diseases increased from about 12.1 million in 1990 to 18.6 million. And it's getting worse for both males and females. And that's in 2019. So what is the solution? I would pose that the solution is physical activity. And this is a quote from Thomas Friedman. He is the former director of the CDC. And he called physical activity the closest thing that we have to a wonder drug. And so why did he say that? Well, it's accessible to everyone. It is cheap, in fact, free to everyone. It is incredibly effective for not only cardiovascular disease and risk factors, but for many other diseases and health ailments. And it's beneficial in almost all aspects. The one asterisk here is that perhaps in people with joint diseases, that higher intensity activities may be not the best thing. So how are we doing? Well, on a global perspective, these are rates of physical inactivity. Inactivity means not meeting the physical activity guidelines, and we'll get to that. So the global rate of inactivity is 31.3%. So about a third of our population is physically inactive. This is an increase in 5 percentage points between 2010 and 2022. And these trends are also worsening and is projected to increase to 35% by 2030. How are we doing on a countrywide level? These are prevalence rates of physical inactivity. This comes from the WHO. And this is stratified by age. So if you look at amongst the younger folks, adolescents, 11 to 17, 64% of males and 81% of females are physically inactive, and this is really bad. As we go into the adult age range, 32% of males and 48% of females are physically inactive, and those numbers get a little bit worse into older age, 70 plus, 47% in males and 65% in females. So this is really unacceptable. Very high rates of physical inactivity. And then looking at it from a state-by-state basis, just from a more of a global perspective here, I think, looking at the Deep South, that's where our highest rates of physical inactivity lie. If you look at where you guys are in New York, it's about 25 to 30% or so, maybe slightly better where I am in DC, but really, these rates are quite high. So, why is this important? Well, that's because there are deaths attributable to low physical activity or physical inactivity, which are quite high. These are trends. Again, this is also from the Global Burden of Disease study from 1990 to about 2021. And so over about 20 years or so, these deaths due to low physical activity have increased by about 5,000 or so, going from roughly 25,000 to 30,000 in 2021. So what are the benefits of regular physical activity? If we just focus on the right in adults, we see improvements in cognition, quality of life, sleep, weight, bone health, and physical function. And then reductions in all sorts of diseases, all-cause mortality, cardiovascular mortality, cardiovascular disease, many of its associated risk factors, hypertension, type 2 diabetes, improvements in the lipid profile. Physical activity is associated with a reduction in 11 different types of cancer, improvements in dementia, psychological health, depression, as well as falls and fall-related injuries. On a more granular level, looking at benefits specifically for cardiovascular disease, I'm not going to go through all of these, but physical activity is almost pleiotropic in what it does to reduce incidence and prevalence of cardiovascular diseases. There are anti-atherosclerotic, anti-arrhythmic, antithrombotic, as well as anti-ischemic effects. So really, it tackles cardiovascular disease on a broad spectrum. Okay, so getting to the guidelines, and I just chose a guideline. This is the World Heart Federation, guideline, but every guideline is the same. The US guidelines, the Canadian guidelines, the WHO, they're all roughly the same. And they propose at least 150 up to 300 minutes of moderate intensity aerobic physical activity per week, or at least 75 up to 150 minutes of vigorous intensity physical activity per week, or some combination of both. In addition to the aerobic component, there's an anaerobic or a muscle strengthening component, so getting 2 or more days a week of muscle strengthening activities. But that's just sort of the baseline. They suggest that more is better, and you will continue to gain benefits further you go. They also make recommendations to limit the amount of sedentary time and to replace sedentary time with physical activity of any intensity, including light intensity, which provides health benefits. And I think that part is key. I think it's lost on many of us until I got into this area of literature, that the thought is that you have to do higher intensity activities to gain benefit. But that isn't the case, and I'll show you why here in a second. But any physical activity, even light intensity activity, can result in profound cardiovascular benefit. Okay, so let's talk a little bit about intensity. Intensity is important to know not only for the guidelines, but also to understand the physical activity epidemiology literature. So absolute intensity is the rate of energy expenditure required to perform any physical activity. It can be measured in many different ways. Of course, the gold standard, many of us know in cardiology, is peak VO2, that you get from a cardiopulmonary exercise stress test, but that's not feasible for the vast majority of people. So it's continually measured in METs. It can also be measured in kilocalories or joules. So 1 MET is the rate of energy expenditure at rest equal to an oxygen uptake of 3.5 milliliters per kilogram per minute. And there are MET categories of intensity, and oftentimes the literature uses these categories when stratifying patients. So sedentary behavior is considered anything equal to or less than 1.5 METs. Light intensity activity is 1.6 to 2.9. Moderate is 3 to 5.9. And vigorous intensity physical activity is considered anything 6 METs or above. So again, this is more important for understanding the literature because many studies quantify physical activity in METs, minutes or maybe hours per week. So this gives you a sense of intensity over the course of time. So it's a nice metric. So let's just go over this to sort of understand what this means. So put another way, 1 MET is the energy it takes to sit quietly in a resting state. And this represents the cost of physical activity as a multiple of the resting metabolic rate. So for example, if you were exercising at 5 METs, you're expending 5 times the amount of energy compared to the energy required at rest. If you were to add MET minutes, that would be exercising at 5 METs for 60 minutes. So that's 5 times 60, which is 300 MET minutes. And then MET minutes per week are the MET minutes accumulated over the course of 7 days or a week. So that's 5 METs at 60 minutes for 3 times a week, for example, would be 5 times 60 times 3, which is 900 MET minutes per week. And so if you extrapolate these numbers to the physical activity guideline recommendation, that's roughly equivalent to somewhere between 500 to 1,000 MET minutes per week for health benefits. So, when explaining this to patients, sometimes they may ask you, if they do exercises, how does this equate to these different intensities? So there's the physical activity compendium, which has come up with various activities and how that sort of translates into METs. And so this comes from the compendium, specifically from the physical activity guidelines. So just some examples here: moderate intensity activity, walking, cleaning, mowing the lawn, light bicycling, doing badminton, maybe doubles tennis. And then vigorous would be things like hiking, jogging, shoveling, carrying a heavy load, fast bicycling, basketball, soccer, and maybe singles tennis. Although I think the important caveat here is that these need to be individualized to the person. So, for example, I think if Roger Federer and Rafa Nadal are playing doubles tennis, they're probably engaging in vigorous intensity physical activity and not moderate intensity physical activity. Okay, so how do you describe this stuff to patients? And I think this is sort of the challenge with our guidelines, is that we don't talk and patients don't talk in this sort of language. And so there's probably two ways to sort of describe this to your patients when you're describing physical activity and prescribing physical activity. The guidelines mention something called the sing-talk test. And so in this way, light intensity would be where one could sing while they're engaging in exercise. Moderate would be where one can talk but not sing. And vigorous is where you can't do both. You can't sing nor talk because you're exercising so vigorously. The other is just using something like a 10-point scale, like the Borg or the RPE, where light would be somewhere from 3 to 4, moderate 5 to 6, and vigorous would be about 7 plus. Okay, so this is maybe one of the most important graphs that comes from the physical activity guideline from 2018. And this is sort of your classic dose response curve for physical activity and how it relates to almost any outcome. Specifically, this is the hazard ratio of mortality, and that's on your y-axis, and then on the x-axis is the amount of physical activity, and specifically this one's looking at MET hours per week. So there's a couple things that are important to highlight here. Number one is that there's no lower threshold for benefit. And then there's a steep early slope here. And what that means is, going back to what I was mentioning previously, is that if you go from being very inactive to just a little bit active, there is a robust reduction in the hazard of mortality. So really strong benefit with even light intensity physical activity. There seems to be no obvious best amount. And here we're kind of reaching our guideline recommended levels here, sort of in this middle range. And then, they mentioned there's no evidence of an increased risk at high end. But I think here, and maybe one way to put it to patients that I think can be encouraging, is that once you reach that guideline, there's sort of diminishing return here. You will get additional benefit, which is why the guidelines recommend to you can potentially go above their recommendation. But the benefit is much less. So, it's probably a good message for patients that even if they don't get to that recommended number, as close as they can get, and even if they go a little bit above, it is just fine. Okay, so there's one thing that I just wanted to harp on here a little bit more. And there are two things here. Number one, limiting the amount of time spent being sedentary. Let's touch a little bit about the data for that. And then replacing sedentary time with any amount of physical activity. So this is another graph from the guidelines. And this is a meta-analysis looking at dose response curves between sedentary behavior and all-cause mortality. And this is something that I think we all know sort of intuitively. In this graph, we have the level of sitting and the hazard ratio for mortality. And as you sit more, the hazard ratio for mortality increases. This is a particularly nifty study. And this study was done almost 10 years ago now, looking at the joint association between physical activity and sedentary time on mortality. And here the question that the authors tried to answer was, can you sort of remove the risk of long bouts of sedentary time with physical activity? And what they showed, I think quite eloquently, is that potentially the answer is yes here. So if we look at the x-axis, within each of these categories, there are quartiles of physical activity, with the highest amount of physical activity on the left, and then going here towards the right, lower quartiles of physical activity. And within each of these quartiles, we have differing amounts of sedentary time. So if you were to take the quartile on the left here, this is the highest amount of physical activity. This is in Met hours per week. And you were to compare the referent group, which is not being very sedentary, less than 4 hours per day, versus being very, very sedentary, sitting greater than 8 hours per day. That difference between the referent group and here is really not very much. And so I think what this demonstrates is that even if you do a whole lot of sitting, if you're very active, you may be able to offset that detrimental effect of being sedentary. And so I think it's sort of an encouraging message again for patients. It's certainly encouraging for me as somebody that sits for long periods of time in my desk. If you can get after it maybe on the weekend, you can sort of offset that detrimental risk of being sedentary. All right, so then that next point in the guideline, replacing sedentary time with physical activity. Well, what's some of the data on that? This is something that I was keenly interested in, and there's a nifty epidemiologic model called isotemporal substitution that can potentially be utilized to answer a question like this. Isotemporal substitution was originally developed in the dietary world, where if you were to replace food with poor nutrition with something with more nutritional value, how does that affect some sort of outcome? So that model has been utilized in the physical activity world to understand how replacing, say, 30 minutes of sedentary time with more active time, how that changes cardiovascular health. And so this is just a schematic here to understand this model, isotemporal substitution. If you were to replace sedentary time with light intensity physical activity, or with moderate to vigorous physical activity, how does that change cardiovascular health? And so this is a paper that I wrote as a fellow utilizing data from MESA. MESA Exam 5 is where the sleep ancillary study was done. And the sleep ancillary study included actigraphy data or accelerometry data. So we were able to have 24-hour measures of not only light and moderate intensity physical activity, but also sleep. And so we can look at these relationships to understand the outcome here, which was Life Simple 7. We didn't have Life Essential 8 at the time, but this is to look at Life Simple 7 as the definition of cardiovascular health. And so here in the top left, the way to read this, these are beta coefficients here. So dropped means if you replace 30 minutes of sedentary time into each of these variables, how does that affect overall cardiovascular health score, Life Simple 7 score? And the asterisk means that it's statistically significant. So you get benefit, an increase when dropping and moving 30 minutes into light intensity physical activity. You get a robust improvement when switching into moderate to vigorous physical activity, and then also an improvement when substituting for sleep as well. And so here on the right, we broke it down by each of the individual components. And so, as you would suspect, when you drop 30 minutes of sedentary time from moderate to vigorous, you're going to get the most robust benefit. And this is the overall cardiovascular health score here. Going to the right means going up, going to the left means going down. Some of these relationships are non-significant, but we see reductions here in systolic as well as diastolic blood pressure. We actually saw a slight increase in total cholesterol, and then some nice reductions in BMI here. So then the question became, well, why did the total cholesterol go up? Which is maybe the opposite of what we would suspect. So we did one more additional analysis, and we looked at LDL versus HDL cholesterol, and it's actually what we would expect. And so there was no association with LDL cholesterol, but when you substitute sleep for light or moderate to vigorous physical activity, the HDL goes up. And this is what we expect. We think that physical activity may have very, very modest, potentially null effects on LDL cholesterol. But really what exercise does is it increases HDL cholesterol, and that was significant with what we found in our study. So next, let's transition a little bit to steps. I think many of you in clinic, as well as myself, we get lots of information from patients now from their step counters. There's been a tremendous growth in consumer-based trackers, wearables, smartwatches, etc. What I like about steps is that they're very easy to measure and understand, both from the patient's perspective, but also ours, as opposed to trying to decipher moderate to vigorous physical activity. And it's also an easy way to prescribe activity to our patients. But I think maybe one of the most salient questions about some of these step counters is how accurate are they? Do they work very well? So this is a small study, but I think a nice study that was done in 2015, came out in JAMA. And here what they did was they had participants that were asked to walk on a treadmill at 3 miles per hour, so sort of ambulatory, for both 500 and 1,500 steps. They had an independent observer count steps using a tally counter. And then they had each participant utilize 10 different applications or devices, and they looked at some of the top sellers in the US at the time. And then they made comparisons between direct observation and device measured steps to see how closely they correlated. And here, if you can see on the right, on the top, these are device outcomes for the 500-step trials. At the very bottom, the Digi Walker, that's the pedometer, so that's the most accurate. So if you compare, maybe the Fitbits are the most accurate compared to the pedometer, but really all of these are roughly accurate. If you look at figure 2 on the bottom, device outcomes for the 1,500-step trial, I think those confidence intervals tighten up even more, and especially the Fitbit seems to be the most accurate. But I think the message here is that these device-based measures are pretty accurate for ambulatory stepping or walking. Where they become inaccurate is with higher intensity activities, so for running, for example. But for many of the patients that we see, they may not be running, or maybe they can't run. So for ambulatory walking, these things are pretty accurate. And this study's fairly old at this point in time. I can tell you that some of the more contemporary step counters are even more accurate now than they used to be. All right, so the next question is, what is the magic number? How many steps per day should our patients be getting for health, and for cardiovascular health more specifically? And we've had this number ingrained for a very long time, but where does the number come from? Well, it's maybe surprising to learn that it comes from zero data. In fact, it was actually created by a Japanese marketing company to sell a pedometer in the 1960s. This was when Japan was hosting the Olympics, and this company had a pedometer called Manpo Kai, probably mispronouncing it, but this pedometer literally translates to 10,000 steps meter. So this magic number came from the 1960s from a marketing company. It had no data to sort of back it, but it was just a nice round number that's carried forward throughout history. Well, it turns out that number is actually pretty accurate. I think, this is the study that came out in 2020 from Pedro St. Maurice at the NIH, and this was probably the biggest study to come out at the time, looking at the association between steps and mortality. And this is data from NHANES, and this is looking at steps per day and then mortality. And as you can see, this is your classic dose response curve, just like looking at that met hours per week from guidelines, is that you see a robust benefit going from not a lot of steps to just a little bit, say going from 2,000 to 4,000 steps per day. And that benefit seems to nadir somewhere around 8 to 10,000 steps per day. They also stratified this study by sex. So on the left, we have males versus females. And as you can see here, the nadir, and if you look at the shapes of the curve, the nadir seems to happen a little bit further down the line with men versus women. So there's some differences there by sex. And then if you look at it by age as well, these curves are very different. So you see the most benefit for older folks, 65 years and above. That benefit seems to be less for those that are 50 to 64. And then even less benefit for folks on the younger side, 40 to 49. And I think what's important to know here is that NHANES in general is a relatively healthy population that don't have a lot of risk factors. So just something to consider when interpreting this data. Well, there were two big harmonized meta-analyses that came out from Amanda Paluch looking at this particular study is daily steps with cardiovascular disease. These are restricted cubic splines, and basically we have older adults on the left, 60 years and above, and then on the right, younger adults, less than 60. So looking at the curve on the left, among older adults that are greater than 60 years of age, somewhere between 6,000 to 9,000 steps per day was associated with a 40 to 50% lower risk of cardiovascular disease compared to folks taking about 2,000 steps per day. And then if you look at the right, again, the younger folks, they seem to sort of maximize their benefit somewhere around 8,000 to 9,000 steps per day as well. So, I think the take-home message here is that there are differences by age, and the older you are, the less steps you need. The younger you are, the more steps you need for obtaining benefit. So this is cardiovascular disease. What about all-cause mortality? This is the same data set with the same authors. This one came out in the Lancet Public Health. And again, they're stratifying by age here. So the red line are adults less than 60 years. And they found that mortality benefit levels somewhere around 8,000 to 10,000 steps per day. And then for those that are greater than or equal to 60 years, the benefit seems to level out around 6,000 to 8,000 steps per day. And there's little additional benefit beyond these thresholds here. Okay, next let's transition to potential harm of higher intensity physical activity. I became interested in this uh, when I ran my very first marathon. So this is a picture of me. This is my last year of medical school in 2014. After me and my buddies finished this race in North Carolina, and at the very end of the race, my friend on the right, Vance, this guy on the right here, and I were approached by a woman from a local news station, and she asked us, you know, what did you think about the death that happened during the race? And we had no idea that there was a death that happened during the race. We were really shocked to hear this and really just sort of flabbergasted. Um, and this is not uncommon. At least we thought that it was not uncommon. You hear about this all the time in races, New York Marathon, Boston Marathon, for example. There always seems to be some sort of cardiac event happen. And so I became intrigued in these and, thinking what are the potentially the harmful effects of higher intensity activity in folks that are seemingly healthy if they're running marathons and half marathons. So, going back to this dose response curve from the guidelines, they mention there's no evidence of increased risk at the high end, but this is probably false, and we're learning over the past couple of decades now that there may be harm, in fact, at the higher ends of physical activity. So one of the studies was the RACER trial. Now, this was a trial that specifically looked at cardiac arrest among folks running marathons and half marathons. So it's a very small, only 49 arrests, so not a lot of outcomes to look at here. But still, enlightening, I think. If most of these happened during the marathon, 40, and then 19 during the half marathon. And the incidence rate here per cardiac arrest, one cardiac arrest, was about 1 in 184,000 participants. So, we hear about it a lot on the news, but it's actually not that common, maybe not as common as one would think. And if you look here in the graph, what is the underlying cause here? And for the survivors here in red, it seems to be myocardial ischemia. And then for the non-survivors, as many of us see in the younger people, it potentially is this hypertrophic cardiomyopathy. And then there's a whole slew of other things down here as well. So this is sort of consistent with what I remember learning in medical school. But I think this is starting to change. Classically, when we think of sudden unexplained death, hypertrophic cardiomyopathy in a young person comes to mind, maybe a channelopathy. But we shouldn't overlook atherosclerotic disease. And in this particular study, this was sudden death in young adults, and this was an autopsy-based series. And here they're stratifying by age, less than 35%. If you look here, atherosclerotic disease, 23% in the young folks, unexplained, maybe more common, but this is more common than hypertrophic cardiomyopathy. HCM accounted for 13% here, and atherosclerotic disease accounted for more, 23%. We know that people that are older, greater than 35, those numbers skyrocket to 73% here. But I think the take home is that we shouldn't overlook atherosclerotic disease in some of these younger people, where typically we would. And with cardiovascular disease rates, cardiometabolic disease worsening, I would imagine that these numbers are probably increasing as well. So let's look at some of the data here, looking at relationships between lifelong exercise volume and coronary atherosclerosis in athletes. This is specifically looking at presence of CAC, so anything greater than 0 here. And if we just focus on very vigorous in hours per week, in their fully adjusted model, there seemed to be a 40% increased odds of CAC in the very vigorous group. Now, looking at this in volume, greater than 2,000 minutes per week, odds ratio of 3.2, so very, very strong positive association with high amount of volume of exercise, doing a lot of exercise in CAC. So what about coronary atherosclerosis? This is essentially the same analysis, but instead using a CCTA, so looking at coronary athero. And similar relationships here with very vigorous exercise intensity in hours per week. There's an significantly increased odds of any amount of coronary athero on coronary CT, 1.56. And then looking at MET minutes per week, greater than 2,000, odds ratio of 3.35. Another study looking at sort of similar associations, something that commonly, I think many of us see in clinic, I know that I do, patients that come in primary prevention with a lot of CAC, how safe is it for me to engage in exercise? Is this okay for me to do? This was a nice study that comes from the Cooper Clinic in Dallas, Texas. And here they had two categories, people with less than 1,000 CAC, less than 100 and greater than 100 CAC, and then stratified by how much physical activity they're doing. There was a statistically significant decrease in all-cause mortality in the folks that had less than 100 CAC participating in the highest amount of activity. These others here are essentially non-significant, but the message is that there's no increased risk. I think that's the most important thing. However, this particular study from the Cooper Clinic is not very generalizable. This was only men. It's self-reported physical activity, so it's really not very generalizable. So, I read this study with a lot of intrigue, and I wanted to reproduce it in a more generalizable population. So some colleagues at Wake Forest, where I did my fellowship, did a similar analysis in MESA. And MESA has 4 different racial ethnic groups, and there is one component that has accelerometry measured physical activity, as I mentioned. So, similar take-home message here, particularly looking at incident cardiovascular disease amongst the highest quartile of physical activity, less than 100 calcium score against units. There's a statistically significant decrease. And then there's also decreased risk for both greater than 100 CAC and less than 100 CAC for those that engage in higher intensities of activity. And then we stratified this by race, ethnicity. There's 4 in MESA. There's white, Chinese, Black, and Hispanic. There's some differences here, some heterogeneity by race, ethnicity, but again, I think the most important take-home message from this particular study is that there's no increased risk. So some evidence here that it's still beneficial, potentially decreased risk, and it's safe in people with higher calcium scores in primary prevention. So what's the mechanism here? We're not really sure. These are just proposed mechanisms. We know that exercise acutely increases parathyroid hormone, which can lead to arterial calcification. Vigorous activity increases stress on the coronaries, which can lead to disrupted flow, which can elevate blood pressure, increases shear stress, which can accelerate atherosclerosis over time. We know that high intensity activity increases oxidative free radicals, which can lead to systemic inflammation. And potentially one of the mechanisms here is that although it may increase the calcium score, specifically thought is that it increases the density of CAC as opposed to maybe the volume or the area. And we know that a denser plaque is, we think, a more protected plaque, less prone to rupture. So, this is sort of analogous to what statins do to the calcium score. It increases the density. So potentially it's a protective mechanism, although the jury is still out. Next, just briefly, we'll touch on physical activity in AFib. There's been, for more than a decade now, observational evidence that high intensity physical activity leads to an increased risk of AFib. This is a meta-analysis here that basically shows that among several different studies, pretty consistent. This is looking at the cumulative years of exercise, so less than 10 and then by 10-year increments, and basically looking at AFib and flutter, that the higher cumulative years of exercise that an individual does leads to a higher, this is an odds ratio of incident AFib. So this is dose response association between physical activity volume and AFib risk. This is sort of a theoretical framework here. And even in our most recent AFib guidelines, they do recommend physical activity. But there may be a point where too much physical activity can lead to an increased risk. And at least in this sort of theoretical framework, it's somewhere between greater than 55 met hours per week of activity or 9.5 hours of vigorous physical activity per week. So what are the mechanisms here? Again, these are theoretical. Potentially there's inflammation and fibrosis, an increase in vagal tone, enhanced sympathetic stimulation during exercise, the athlete's heart phenomena, dilation within the atria and the ventricles, potentially some hypertrophy, increased shear stress can lead to a vagally mediated shortening of the atrial refractory period, some stretch, atrial inflammation, atriopathy, scarring, and potentially leading to atrial fibrillation. I may just skip over this for time, but the last component of this is that there's some reasonable data, CMR looking at myocardial fibrosis. There have been several studies that have shown looking at LGE in athletes versus non-athletes as the control, higher rates of LGE, suggesting higher amount of fibrosis. But the caveat here is that these studies are very, very small. And so it's hard to sort of take away some of this information. So, there was a really nice AHA scientific statement that came out in 2020, led by Barry Franklin. And this table sort of summarizes a lot of different studies looking at cardiovascular diseases at different volumes of exercise. And so here, if you look at the exercise type and volume across these studies, differing types of exercise, different ways of measuring exercise. And the main thing here that I want to point out is that if you look at the optimal group versus the most active group, there's a difference here. So the most active group doesn't seem to gain the most benefit. If you look here at health risks, if you look at the hazard ratios seem to be the most robust in a group that is not the most active group. And so based off of this, we have this conceptual framework, again, of physical activity and cardiovascular health. And we know that there's a great evidence to suggest that there's a dose response curve. The more activity you do, the better. And, we used to think that there may be the most benefit the further along the curve that you go. But I think more and more evidence now is suggesting that there may be a point that is not the extreme. So that there may be an optimal area that is not the furthest along the curve to where you may start to see some potential harm here. All right. So we'll end on an exercise prescription and recommendations. And what I think the easiest way to remember this is the acronym FITT, F-I-T-T. That stands for frequency, intensity, time, and type. So the frequency, at least 3 days a week. This particular framework comes from the American College of Sports Medicine. Intensity, somewhere between 40 to 59% of the heart rate reserve. We'll get to that in a moment. And or vigorous, which is 60 to roughly 90% of that heart rate reserve. Time, anywhere from 30 to 60 minutes a day of moderate, or 20 to 60 minutes of vigorous, or some combination of the two. And then type, patients often want to know what's the best type of physical activity. There is no best type of physical activity. It's whatever the patient is going to do for the long term, because this is all about cumulative exposure to this beneficial activity. So it's whatever the patient likes to do is probably the best type of physical activity. There are many different ways to sort of talk about intensity here and how to describe that to patients. I'm not going to go over these in detail. I think what most of us are familiar with is 220 minus age being the heart rate max. The ACSM doesn't like this one because it can under or overestimate. That being said, I think it's intuitive for us and it's probably close enough. And that's what I use when prescribing physical activity. There are all sorts of validated equations here. Again, they're very similar to one another, so I'm just going to skip over this. And then there's a great AHA scientific statement that came out earlier this year, also by Amanda Paluch, who did the studies on steps in that harmonized analysis, to discuss how to prescribe resistance training. Again, the recommendations are 2 times per week of resistance training. And we'll just focus here in the middle of moderate intensity. This is probably where we should start with most people. So 40 to 60% of the 1 rep max, generally 8 to 12 reps on 2 or more days per week. And here, when you're doing 40 to 60% of the one rep max, 8 to 12, that the focus there is on strength and endurance. If you do a higher rep max on less reps, for example, that the focus there is on strength. And then the opposite, if you're doing lots of reps at a lower intensity, the focus there is more on endurance. And lastly, we need to counsel our patients on physical activity. There's been the American College of Sports Medicine for a long time has been proposing this, that physical activity is a necessary vital sign, and we need to do a better job of assessing this in clinic. And I know what you're going to say. I say the same thing. We don't have enough time to do it, but there are many different ways to do it, and we can utilize our personnel. I know I certainly do. So it's not just on us. We can have nurses, MAs, ancillary staff to help assess physical activity. And lastly, prescribe ultimately physical activity. So this is an exercise prescription. I print these out for my patients. And it's just a very simple exercise prescription where you can check off what you think are the metrics for the individualized patient. There's pretty good data that shows that prescribing physical activity, just like any other drug we would prescribe, does lead to positive behavior change, and something simple that we can do for our patients. So in conclusion, cardiovascular disease rates are increasing, and deaths attributable to physical inactivity are really unacceptably high. Don't forget the guidelines: at least 150 to 300 minutes of moderate, or 75 to 150 minutes of vigorous physical activity per week, or some combination of the two, are what guidelines recommend for health benefits. That's in addition to doing 2 days per week of muscle strengthening. For steps, 10,000 may be overkill, actually, and it depends on your age. If you're less than 60, this is what I follow, which comes from those meta-analyses, somewhere between 8 to 10,000 steps per day. And if you're greater than 60, somewhere between 6 to 8,000 steps per day is probably enough. There are potential harms of high-intensity physical activity. Now, we don't see these folks probably too often, but we do need to be aware of this and sort of counsel our patients. And these are areas of active research. Don't forget to prescribe physical activity fits, frequency, intensity, time, and type, and to measure physical activity because it is a necessary vital sign. And that's all I have. Thank you very much for your attention.
Thank you very much, Charles. That was a great lecture and reminds us of how important physical activity and exercise are. Please now put your questions in the Q&A and we'll go through them. I will start with a question that I think is very important now with the use of GLP-1 receptor agonists that have shown to decrease the muscle mass, right? And the question is more of a global question. What are your thoughts on muscle mass, or maybe measuring body composition, and how do you pair exercise when you use GLP-1 receptor agonists with your patients?
Yeah. Great question. When we talk about physical activity for cardiovascular health, usually we put more emphasis on the aerobic component because the data for muscle strengthening and cardiovascular diseases is sort of mixed. It's not quite as clear. But when you're losing a lot of weight, muscle strengthening exercises is maybe one of the most important things you can do, with the idea that muscle strengthening can help preserve lean muscle as you're losing weight, because regardless of the mechanism of the weight loss, whether you do it by yourself or with the drug, inevitably you're going to lose a lot of fat mass and muscle mass. And what we're seeing now commonly is this sort of yo-yo effect. As patients take the drug, they lose muscle and fat mass, but then they lose their prescription, or their insurance isn't covered anymore, or it's on backlog, for example. Their weight goes right back up, but they're not regaining that muscle mass. It's only fat mass, and so they end up in a worse spot than where they started. So, of course, aerobic exercise is important when patients are on GLP-1s. I'd say the muscle strengthening component is almost even more important. So we really need to do a good job of counseling our patients. And then the diet is also important. At least the dietary recommendations for these drugs are 0.8 grams per kilogram of protein. And so focusing on protein to enhance, or I guess, offset the potential muscle loss with weight is important. So the diet is also very, very important.
Thank you very much. I couldn't agree more. We have a comment from Rob Osfeld. He says, thank you for a great and informative talk. In regards to CAC and exercise, is there data that if you stratify levels of exercise by dietary pattern, diet might impact the degree of CAC? And I'm not sure on if there's any data in general on plant-based diet and CAC. Maybe you can share, Rob, if you know about it. For example, he says, in a high-intensity exercise group, might consuming more plant-based nutrition be associated with a lower CAC compared to more animal-based foods? Tangentially, there is data that consuming more green leafy vegetables, beets, can both improve exercise performance, perhaps by improving efficiency of mitochondria and reduce delayed onset muscle soreness.
Yeah, I mean that's a great question. I think the mechanism of increased CAC in high intensity exercisers is not clear. Is diet potentially one of those confounders? I think it's very plausible. I think you would intuitively think that people engaging in higher intensity activities maybe potentially are eating a lot of red meat. TMA for TMO, excuse me, for example, is that contributing to the increased calcium scores? It's very possible. These studies are small, they're observational. They may control for diet, but there's a lot of imprecision there. And so certainly more of a plant-based diet is advisable, I would say. But there's a lot to be learned for sure.
Yeah, in particular, I think when people are doing this kind of triathletes or Ironman training or marathon runners, they need to compensate for the expenditure of calories, and to do that in a healthy way, I think it can be quite challenging. So I agree in reinforcing a healthy diet. And another thing, sometimes maybe alcohol, right? And increased alcohol consumption with high exercise volume is something that can happen, I think.
Yeah, well, even when thinking about alcohol, a lot of these races, there's like a beer run, right? So you go drink a beer right after the race, and it's more of a social thing. And particularly when we see increased risk of AFib in some of these higher intensity, and we think about the component of alcohol there, is that contributing as well? It's probably not the best thing for the heart.
Yeah, hard to measure that in these trials, but very important as well, right? So, question from Daniel Lorenzati. Thanks, that was great. Given the recent success of GLP-1 and GIP agonists, how can patients be still encouraged to prioritize weight loss through physical activity rather than using these shortcuts?
Yeah.
Shortcuts. I mean, not we don't, but the people in general, yeah.
Yeah, no, fantastic question. I think, even from the prescriber's perspective, it seems like the silver bullet, right? We don't need to worry about or even think about trying exercise or physical activity first before jumping straight to the drug. And I think we know that physical activity in and of itself is not going to cause weight loss. It's just not going to do it for the vast majority of people that have overweight or obesity. But there are many other things that it does do besides just lead to reductions in weight. There are global cardiovascular health benefits. It improves your cardiorespiratory fitness regardless of your BMI. And we know that fitness is maybe the strongest predictor of outcomes, cardiovascular outcomes. There's psychosocial benefits as well. And so I think, when talking about physical activity to your patients on these drugs, we should acknowledge that it may not be leading to decreasing BMI or decreasing your weight, but there are so many other things that it's positive for, and it certainly does augment, I think, the effect of these drugs. And if you look at the trials for semaglutide and tirzepatide. There's a small additional benefit with, when they engage in a sort of structured exercise program.
Thank you very much. We have a few more questions. So we have one from General Sod. As a peloton rider since 2015, I am curious as to your opinion on heart rate-based training versus power zone training.
What was the last one? Power?
Heart rate-based training versus power zone. These power zones 1, 2, or 3.
I see.
Watts and
yeah. I think it probably doesn't matter. Is my personal opinion. Peloton and some of these other exercise programs, these zones are proprietary, right? We don't really know what they mean or where they're coming from, or are they based in the literature or not. That being said, I think it's motivating for a lot of people as well. I know it can be motivating for me, certainly, sort of looking at your numbers and seeing how it increases. It motivates you to work a little bit harder. So I put less sort of confidence in these measures from a precision standpoint, but if it helps motivate you to exercise more or work harder, then great.
yeah, I think related to that is also the question of how much exercise, volume affects each person differently, right? Because I mean, if you see Federer training or playing tennis, it's probably very different than if I play tennis or with this conditioning to exercise. But it's hard to study that in trials, right? In these large trials.
Right.
Yeah. So we have from Ankur, one of our fellows. He says, "Thank you for your talk, Dr. German. I'm not sure if you remember me, but I really enjoy getting to work with you in the inpatient cardiology service at University of Chicago as a resident." He says, "I'm a first-year fellow at Monty now. I try to talk to my clinic patients about physical activity, particularly these days, as people are thinking about New Year's resolution." I do the same, Ankur. Great. How often do you see your patients after prescribing exercise, and how do you hold them accountable? Great question.
Yep. Certainly it depends on what other comorbidities that may have that probably drives the follow-up and when I'm going to see these patients. The exercise prescription shouldn't necessarily change. And so if that's the only reason they're seeing me, then maybe it's a one and done. But if there are other things going on, if there's concern that there may be increased, if these are high intensity activity folks, there may be a role in stratifying their risk with a calcium score, for example. So, of course, also dependent upon symptoms, if you're concerned about things like AFib. Again, this is a pretty rare population, though. So for most folks, it's sort of understanding their risk, which is sort of baseline preventive cardiology 101, and then prescribing exercise. And if they have other additional risk factors, then maybe that may lead to further visits down the line. How do you hold them accountable? I do use the exercise prescription. I think that's one way to sort of say, okay, this is what you need to be doing for benefit. And then if I do see them again, I follow up. I make a goal, something that's reasonable, and then I'll make note of that in my note. And when I see them again, I'll say, all right, how have you been doing? Did you hit this step goal or did you hit this MDPA goal? And we discuss it.
That's great. So important. And there are some new app-based kind of platforms coming with this, right? There was some data in AHA with a heart failure with preserved ejection fraction and some app-based encouragement and training. Are you using any particular apps? Or I'm not trying to make you endorse, but do you find any of these helpful?
I haven't explored the apps all that much. Because I'm always just concerned about sort of proprietary, where are these numbers coming from? And to be honest, coming from the University of Chicago, I just started at Georgetown a few months ago. That population, was more on the proximal side of that dose response curve. Just trying to get them to exercise was a win. And I wasn't really getting to some of this precision stuff that I was talking about today. So, things may change here at Georgetown since starting here, that their population is a little bit different. But no, the short answer is no, I haven't been using any apps.
Right. So another question from Daniel Lorenzati. What do you think of this concept of weekend warriors versus more regularly distributed physical activity? Is the benefit the same? Great question.
Yep. Great question. There actually is pretty good literature that has looked at this phenomenon, at least in the epidemiology studies, and they looked at, total amounts or exercise volume accumulated over 2 days versus more spread out over, say, 5 days, with the 2 days being the weekend warrior subtype versus sort of regular exercise. And then they look at incident cardiovascular diseases and outcomes, and they're the same. So again, I think this is another sort of a win thing for our patients, is that the pattern of accumulating your physical activity doesn't seem to matter. Still a little bit of gray zone here. There's still some debate within the community, but I think most would say that it doesn't matter. And there's reasonable data to suggest that. So however you can get it, whenever you can get it is good.
Just try not to get injured with this weekend warriors thing. That's it. And I guess that last question, and so when you talked about certain patients that we treat, patients that have lower physical activity or more sickness, and we're trying to encourage them to do more. And on the different side of the spectrum are the athletes, right? The professional athletes. Do you check calcium score in professional athletes at all?
Yeah, that's a great question. There, at least in the guidelines, it's reasonable when you're, quote clearing a patient for exercise, particularly higher intensity exercise, people that are going to run a race, to do some sort of stress test. So if you can get it approved, I think what would be reasonable is a coronary CT, which I think Leandro would agree with me, being a coronary CT guy, which maybe would provide the most information as far as risk assessment. And someone that's asymptomatic, I think a coronary calcium score is reasonable. We do know that, now we have the PREVENT risk calculator. I think it's to be seen how well PREVENT works compared to the pooled cohort equation. But, many of these people would fall in that low risk group, less than 5% 10-year risk. But we do know that things happen. So I don't think it's unreasonable. If maybe you're not getting a stress test or a coronary CT for whatever reason, to sort of risk stratify them, and they're asymptomatic, to get a calcium score in the appropriate age.
Great. Yeah, I agree with you. Yeah, despite this paradox that we see, there's still probably a lot of value in it. Well, thank you very much. This was wonderful. I enjoyed it a lot, and happy holidays to you. And this is the last lecture of the year, so thank you for making it a great one.
Thank you, Leandro. Thank you.
Okay. Happy holidays, everyone.